Okay, so good. Welcome again, Lab 3. We've got a patient here who is an inpatient we decided to do. We actually had a few cases lined up that I thought would be interesting with little twists. We had a possible clip in ring, and then we had a failed Alfieri, but neither of them could show up for today's case. Unfortunately, this patient is here and really can't get out of the hospital. So he's a 58, 59-year-old gentleman who has a remote CABG history and also has had a renal transplant and a pancreas transplant, and now has acute on chronic heart failure. His really quite a bit of heart failure. Was admitted a couple weeks ago, was treated for possible pneumonia, possible heart failure, that whole thing. Found to have an EF of 30-35% with severe MR that was not due to flail or degenerative leaflet tissue. He was diuresed and sent home. We saw him in the office in valve clinic, and he didn't look good, so we readmitted him. He couldn't sleep at night. He had a lot of orthopnea. He's been on the heart failure service now for 3, 4, 5 days, 4 days, say, with real aggressive medical therapy. Let's turn it over to Jyothy. Please, Jyothy, show us the valve and what you think is important in this case.
I'll show a few images that highlight the findings in this patient. So here's kind of a quick view of the long axis view that shows this infralateral wall motion abnormality and kind of the classic restricted posterior leaflet with a posteriorly directed jet of mitral regurgitation. I'll go on to some of the images that show the pathology here very well. That shows that the mitral regurgitation is severe. By a quick and dirty PISA, you see that the PISA radius is about 1.2 centimeters with an aliasing velocity of 40, suggesting that this is indeed severe MR. We've done some measurements of the posterior leaflet at the P2, P3 level where most of the restriction is, and you see that the leaflet's about 1.2 to 1.3 centimeters in length, and kind of Mark will come to the discussion about how this incorporates into decision-making of the type of clip. I'll show you some 3D images that kind of have really helped us to localize the lesion.
And then while he's finding that, Jim, maybe this panel is awesome. So maybe we can ask some of the panelists about, the etiology here, I think, is much more, there's no flail or prolapse, really. We think we know what we're dealing with here with this LV dysfunction, a guy who's had a remote CABG, so clearly has some ischemic heart disease and wall motion abnormalities. So maybe we can talk to the guys there about, A, where to do the transeptal puncture, and B, what type of clip, because we now have different clips we can choose from, how they might approach this case. There's a valve there in 3D, nice picture.
So here is some of the baseline images kind of zoomed up that shows that most of the restriction in this case is happening around the second and third scallops on the posterior, which is where we saw the most extensive wall motion abnormality. And when you do 3D color, you see that the jet is predominantly right at the center of the valve, kind of posteriorly directed. Again, a reconfirmation of the same. When you look in the ventricular side, here what you're seeing on the top is that really restricted posterior leaflet, again more restricted on the medial aspect at the 2s and the 3s, and an anterior leaflet that appears to be moving reasonably well. So then let me show you, 3 of the 4 pulmonary veins showed reversal. This is the left lower pulmonary vein that shows significant reversal in systole. The left upper shows some blunting, and both of the right-sided veins also show reversal. Again, as Jim mentioned, we are using this along with the rest of the information post-case to show that we've been able to resurrect the pulmonary venous flow back to normal.
Good. So let's move forward, maybe some technical aspects of it. I think Mark asked the question. As far as clip choice on this case, obviously you see we have a clip in there already, but we'll go through the transeptal with you right now. Go ahead, Mark.
Okay.
Here are the bicaval images in an explain, so showing bicaval images on the left side with the image on the right, kind of really helpful when we see nice stenting. And in this case, this patient has pacemaker ICD that kind of also comes into play when we look at this images. You see nice stenting at the leaflet. That seems to be a reasonable height. Image on the right shows that from the location of maximum tenting to the annulus, it's about 4.2 centimeters.
Yeah, so this is an SL1 catheter you can see fluoroscopically that we bring up. And then once we get some tenting on the septum, like Jyothy was showing, typically a little more posterior. And on the inferior aspect of the fossa here, right here, you can see both the fluoro and the echo. And once we find a nice spot, we're about 4 centimeters distance from the valve leaflets, like Jyothy's showing right here with these measurements. We then typically, especially people who've had a bypass, we'll do a bovie of a Brock needle, of a transeptal needle to get through. Why don't you show them that, Jyothy? Yeah, sliding along the septum can give you trouble because then you end up accessing the LA in a spot that you didn't. So we have two reasons for not using the bayless. One is cost, as you mentioned, and the second is because EP does it. So we figured how good can it be?
Yeah, it's a poor man's bayless.
If this was a flail, we would have stuck it at 4.5, 4.3. Part of the job of the echo guys, not just to get the most pretty pictures in the world, to be so facile at jumping from one to the other. It's an unbelievable trait to be able to do that. And Jyothy's awesome.
So this one is a kind of a repeat measurement after we are across, just to reconfirm that kind of it did not slip or anything like that.
Just over 4.
The image before this is kind of where we got the measurement before the bovie here.
All right, let's do the case.
Yeah.
So we brought an XTR in, and we very, very easily steered down to the valve. Sometimes that could be an issue, but in this one it wasn't. So you can see we got the XTR open to about 120, 140, mostly to show the clip arms and make sure that we're perpendicular to the line of coaptation, which Jyothy will show here in a second.
So on the left we have the commissural view showing P1 to the right, the second scallops to the middle, and then P3 to the left, and we see that most of the mitral regurgitation is happening medial, as we saw on the 3D images again. The X-plane images really help us to orient both kind of from a medial lateral aspect to make sure that the trajectory is right, but also on the right side image to make sure that the clip arms continue to be oriented as we want it to be, and kind of that antero-posteriorly we are kind of right in the location of where we want.
Yeah, that's it.
So,
all right, cool. So we're going to, what do you think, close up a little bit and get into this ventricle?
A little bit. We're going to go down.
So on fluoro here, maybe change this so they can see the arms a little bit better. So you'll see me closing up a little bit with this this jumbo jet going in. We like the arms pretty close before we go in. And then under the 3D here, Jyothy is going to show us to make sure we don't, that our clip arms stay okay, that we don't jump medial, that we don't go too anterior, which is what we're seeing a little bit with the XTR. I think we're staying okay. And then, and then we're probably in the ventricle. Show us that, Jyothy.
So in the ventricular aspect, kind of I'm lowering the gain to make sure that the clip arms did not kind of change orientation, and it looks like we are right around the 2s, kind of a little closer to the 3s, and the clip arms seem to be oriented in the 12 o'clock, 6 o'clock position here. We may counterclock a little bit, or kind of we'll decide as we go back to 2D and to commissural images, commissural view with
so I'll open up the arms a little bit so you can see them real well, Jyothy. See that?
Yeah.
And when you're in the 2s, you can go a little deep in the ventricle, although typically you don't want to go too deep. And on the right-hand screen there, you can see the clip arms look pretty good when you're going in the 2s.
And looks like the anterior leaflet nicely falls in already.
A little posterior.
I think the goal now would be to make sure that we tilt enough posteriorly to...
Yeah. So Jyothy and Charlie on the same page. He rotated posterior. I'm going to show you. I'm going to go back and forth, get under the leaflets, then on top of them. And you can see there, maybe the posterior, we need, touch more posterior. We barely need to talk anymore during these cases, but we will here.
A and P in.
And we think they're both probably in pretty well. What do you think, Jyothy?
A and P in, they P looks nicely deep within. A looks nice and deep.
You want me to go ahead and grab? Yeah, maybe you touch medial, Jim.
Slightly medial. We're about 60 degrees here.
That looks good. All right, we'll go back to the grasp and view. And we'll lower the grippers. Everybody pretty cool with this? You want to go nice and magged up, Jyothy, just so they can see? And I'll go real slow here. I think you're fine, Charlie.
Yeah, I'm not going to move it.
You want to mag it up, Jyothy? Or you want to stay on X-plane?
Yeah.
Okay, whatever you want. Here come the grippers down. See them? And then we're going to grab and close up a little bit. With the XTR, you see how the mobility of those leaflets sort of diminished? I'm going to go forward a little bit before I close too much. I'm going to go give back a little bit more because we got these big thing here.
Give a little bit back.
Yeah, live floral is good. So I'm close to about, what, 40?
Yeah,
I think we got a good grasp here. Now, I would say, 90% of the time, Charlie, we have live LA pressures. With the newer system, with the way it's keyed, we get LA pressures 90% of the time. We published on this. Today, we didn't, and I figured out why. It's because we're live. But anyway, we can't show you that dramatic. Sometimes we see this dramatic reduction in LA pressures. Hey, Charlie, what happened to the blood pressure up there? Anesthesia. Did the blood pressure go up?
Blood pressure's been the exact same.
Okay, no change in the blood pressure.
change.
Sometimes we'll see the blood pressure go up and the LA pressures go down.
So insertion looks good, Jyothy. How's it look so far?
Yeah,
from the MR?
it looks so far. I think I think we wanted to go a little more medial, and when you look on the left-sided image, we are closer to the 2, maybe leaning
Yeah.
towards the 3s. I think we wanted, and then so far the clip arms are not fully closed, and what you see is residual mitral regurgitation that's originating around that 3s.
Good.
So I think as you close the clip arms, that
See
will
what
be where we'll be
Yeah.
mainly paying attention
Okay.
to make sure.
Yeah,
Tell
that-
me
so
when-
let's stay live on the echo while
Yeah.
Mark closes up.
Tell me when to close, Jyothy.
Yeah, I'm. Yeah,
Close?
That's yeah.
Closing?
We have some live floral.
And there we are, we're closed.
That looks a lot better.
It looks a lot better. And the question is whether Jyothy's right, which hurts when he is, because it's usual. But we got a little bit of a medial jet.
Yeah.
The question is going to be, do we have anything lateral too? And if we don't, we can scooch over a little bit medial and grab it again. What do you think, Jyothy? 1 plus, 2 plus?
I think it 1 plus and that medial jet, which is the only place the lateral looks nice, and there's nothing there. I'm getting you a gradient that
Awesome.
looks pretty
You
good.
think there's anything lateral? You want to move it over? Or maybe just a hair? That was,
Lateral.
yeah.
So I think
it's a
we'll
little
reassess that mitral regurg and decide if we have to go a little more medially. The mean gradient's about 3 millimeters.
Jyothy wants to go medial.
Yeah, no, Jyothy.
Yeah, I can
He's
hear
a
it. I'm
monster.
with Jim Thomas, JT.
What do you guys think? What does the panel think? Would you
Terms,
scooch this a little medial?
Alan, Amr,
Any of you guys?
Chris.
All of you?
Well, everyone wants to move it. I just want to see more action.
Aren't we just excited that we grabbed something and end the case?
Let's go ahead and see if we can.
Not anymore,
Get a little bit better.
exactly. You live, Jyothy?
All right.
Pulmonary
Well, we're
vein
going
will
to
go
try
to
and get a
zero.
little more medial
We'll-
here.
Yeah.
So Mark,
just
what do you
show-
tell
we
the
just
audience
show
what
a
you're
quick
going to do?
pulmonary
Yeah, so what I did was I took the
Couple ways
grippers
you can
off.
do it.
Yep, came up, and then I opened the clip arms, as you can see by fluoro. And then, Jyothy, just go live. Don't worry about this. We're not going to keep that no matter what.
Nice overview.
And then we have 2 options here, obviously, to go medial. We can just put a little more M on, which sometimes changes your trajectory, or we can pull back the guide a little bit.
Open up. Yeah.
The guide's just about 1 centimeter or 1.5 centimeters in. So I'm going to give a little M here. What do you think, Jyothy?
Yeah, no, I think
Just a
you
touch.
already, your trajectory is already kind of in a place where you are a little more medial than you were before.
Cool.
And I think we are in the right
So let's
place.
come up and see if
Open
you're
up
correct.
a bit.
So we're going to get a 2 for here, 2 grabs and 1 shell. Okay. What do you guys think? You digging that?
It's pretty good.
I ran out of
A
height
little
here,
P,
but it
not much
should-
though. I think you're in
Okay.
on both. Yeah.
I'm going to drop the grippers, guys. Here we go. We're going to close up a little bit. And give back a little bit. Just a little bit. Yeah.
Grasp.
Okay. Looks pretty good.
Yeah, I think that P3 looks like we
Good.
got it.
So we're about
gave back a
40
touch.
degrees, 30, 40 degrees here.
So the leaflet grasp obviously looks great. When there are questions about it, we'll throw the 3D on. We'll look for that tissue bridge, but here it's so clear. And then, Jyothy, when you want, I'll close up.
It already looks better.
I think it already looks better.
Yeah, it already
Good
looks
point.
So I'm doing an explain again, kind of since our concern was that medial orifice, I'm kind of doing an explain there, and I don't see a corresponding pizza on the right side that is significant. I'm right in the middle of the leaflet, and I see whatever residual MR that I see is at the location of the clip, which I think will get better as we close the clip arms.
In other words, you
And I
were
don't
right.
see
This will be
anything
interesting.
lateral.
Yeah, so you're just trying to rub it in.
He's rubbing
let's,
it in, baby.
We'll close up.
All right,
Just
so
keep an
Jyothy-
eye on the live echo.
Jyothy, I'm going to go
Yeah,
close
we are
up.
live.
Here we go. And then we got that's fluoro live too. We close up, and the MR is much better.
It looks good
Tiny
now.
bit on either edge.
Really looks good now.
And, by splitting it, you opened up a tiny bit lateral, but the medial's so much better. This guy's going to feel a lot better.
Yeah.
So I'm cheering. I'm standing up and cheering.
Yeah.
I'm good with that. All right, good.
Let
So,
me do another 3D show there.
hey, Jyothy, what's the gradient?
Yeah.
It was 3 before with the first grasp. Jyothy's going to get it now. Same.
Yeah, looks good.
Beautiful trace in there.
Not much. I think it'll be still around the 3 range. And if you recall, the last time we had a systolic MR spectral Doppler that we don't see the mean gradient.
Or a little
I'm
more than-
obviously kind of measuring
Yeah,
a little more. I
maybe
think
a
it's
touch.
somewhere in the 3.8 range
Yeah.
or so. Kind of.
And we'll see what
definitely.
happens when we release this, huh? Okay, so under fluoro here, I'm going to open with the system locked, so it shouldn't open. And I'll go back, and if you could turn up the fluid for me, big guy. And then we'll take off these silly little gasket things. All right, so you guys can see me. I'm just taking this out. Look how easy this is. Often this is a little wait and see game with the pulsations and all. The downside, of course, is if this embolizes, it's not attached. Minor detail. So that's out. I'm going to take this out. Want to make sure we don't bring any knots down into the system. And this is coming out easy. Always does. And now that this is out, we'll say fluoro, Charlie, please.
Yep,
It's
that's
fluoro, and we'll see if this opens. Of course, should not. We'll go back to kind of loose. Take this grenade pit out. I haven't done this in forever. This is usually your job.
This
You
is
gotta make sure I'm
fellow's
okay.
job here.
Right. Tell me if I'm doing something wrong, guys. I never do this. Okay, why don't you do this, and I'll do this. Spin that 8 times. It's the easy part. I like to have my hand on this bayonet. And remember, that's a gentle pull. This is live fluoro. So, okay. And we'll pull back
Yeah,
a little
we
bit.
see the.
Boom. Off. Good. Want to save that for posterity? Good. Okay, it looks like in fluoroscopy, it looks like a nice stable thing there. You know, sometimes with the Barlows, they move like
Do
crazy.
you want to
but this one-
recheck it, Jyothy? The,
Yeah, we are
MR
gonna-
Yeah, it'll be interesting to
gradient?
show the gradient. All right, good. All right, guys, well, we appreciate it. Thanks for joining us.
The final gradient's actually 3 because I think once you release that pressure, the gradient is actually a little lower than what I got the last time.
Good. So, Jyothy, help me get the bayonet out in
Okay.
2D.
Back to 0.
And this is part of the system that maybe one day will change. None of
Yeah,
us.
this is
It's just a
something
pain, you know.
archaic. Something
So,
medieval.
we
I
just
think.
take our time, a little bit at a time, and just get to the point where we can slip this dog out of here.
On the left screen, you see that.
Yeah, it's a
clear
beautiful
off, yeah.
picture, Jyothy. I'm going to pull this back, Fluoro. You can see I'm pulling back here, nice and gentle. Boom. And you want to come back and pull on this? You know the this thing here. And then, because I like to get him a pressure, get the big syringe.
Mark,
And yeah. Okay. Draw it with this. That's fine. Draw it with this. So draw a lot though. Ready? Yep. Okay, good. And then you're covering me, and I have to be able to see this, big fella. Okay. And then now start drawing now. Excellent. And then let's get a fresh syringe and then flush back. You're the man. Cool.
All right, thank you.
Nice guys. Awesome.
Appreciate it.
Thanks for the help.
thank you.
Thanks, team.
for.
Good. I'll pull back and get an LA pressure too.